what you see in this video?
Yes, I can see a child. He is well alert, appropriate for his age. He looks anxious as well, and having I can see, I can. It's Wheezes are audible.
Hmm.
Wheezes and bronchi are audible, and he is sitting most likely in the hospital setting.
Okay,
So
so
my
what?
most likely
Hmm.
Yeah, my most likely diagnosis is it's a viral induced wheeze.
Yes, I can see here a toddler age or 2 to 3 years age boy who is in hospital setting. The boy is sitting, is unconscious, and there is a respiratory distress occur in the form of tachypnea, chest injury present, and a sound present that is wheezy sound. So on my top, it can be viral induced wheeze. Viral induced wheeze actually less than 5 years of age. Then second, it can be bronchial asthma, early onset, multiple trigger wheezes, and secondary wheezes due to any chronic chest conditions like cystic fibrosis, immunodeficiency, anatomical malformations, bronchiectasis, bronchiolitis obliterans. So what history? Suppose viral induced wheeze. What history was?
Yeah, first of all, I would like to ask the onset, course, and duration of the disease. When did it exactly start first? And is it associated with any cyanosis or apneas or pallor or any shortness of breath, any chest pain, any other lymph node swellings? And is it like how many times? Is it recurrent or is it for the first time? And does it respond to the medications? So which medications does it respond? And as he has the history of eczema or atopy, that's it. Yeah.
Yes, yes.
Any family history. Yeah.
Yeah. So when we take any video station history, we keep in our mind the diagnosis and the DD we keep in our mind. So according to first case usual, the history is the onset, course and duration, first time or recurrent occur. Character of the cough is it chest your weight. So first time or recurrent, we know that repeated occur, the asthma attack, chest cough, cough associated respiratory condition, chest your not. Then any cyanosis, pallor, shortness of breath, chest pain, dyspnea on exertions. And as usual, fever, weight, activity, sleep, and neck swelling, lymph nodes, FWSL. Timing, bronchial asthma timing we know. So is it more at night or the same all over the day? How many times per day? How many times per night? Number of attacks per week and per month is if already known case. Then trigger, some trigger associated with that is like after any cold or triggered by food, exercise, pollens, etc. Is he free in between the attacks? Atopic march like itchy nose, itchy eye, eczema, food allergy. Then family history of similar condition or atopy, home condition, aeration, smoking, garden, pets, nearby constructions. Vaccination status like any extra vaccine, COVID, exposure recently, COVID vaccination of the parents. Any treatment he's taking like inhalers, compliance to the treatment, any peak flow diary team he is following with any chronic illness and growth and development short stature obesity because growth and development sometimes they take steroid there are side effects of also we keep in our mind. So what examination we do?
Okay. Yeah, examination. I would like to go for first airway, whether the airway space patent breathing. I would like to connect to the oxygen saturation and check his oxygen and monitor his oxygen and circulation. I would like to check for the perfusion, and also I would like to go for the complete respiratory examination, including what are the type of wheeze is this, and any yeah, steroid toxicity. Yeah.
Yeah, so the history examination I will do by using first airway breathing circulations because we want to know that which stages vitals oxygen saturation cyanosis alert or not can complete sentence or not. So alert or not can complete sentence or not we know that mild moderate severe is we can search. Then chest examination, respiratory examination, that is expiratory wheeze with prolonged expirations. And if chronic patient on steroid inhaler, we are searching for signs of steroid toxicity, Cushing-Gold features. So viral induced wheeze is a chest related. We just do the chest examination, ABC vitals. What investigation we do?
Yeah, no need for investigation. It is a clinical diagnosis and based on the history. And if it is associated with any superimposed infections, then would like to go for, I would like to go for chest and X-ray. And if other thing I want to monitor, then ABGs and pulmonary function test. If I want, if I am I would like to rule out from asthma, pulmonary function test, and RBG.
Yes. So the investigations of viral induced wheeze is that no need for investigations unless if in the life-threatening asthma or not sure about the diagnosis, sudden deteriorations. And if deterioration occur or any other cause we need to search, then we can do the chest X-ray. Chest X-ray find hyperinflated chest. Pulmonary function test we can do for asthma. Then ABG, urea electrolyte, random blood glucose to monitor the sign of salbutamol toxicity. So salbutamol toxicity we can do the ABG, urea electrolyte, random blood glucose. Otherwise, no investigation actually needed. What is the management of viral induced wheeze?
Okay, so we will only give this reliever inhaler, and we will not give steroids for viral induced wheeze and
Yes.
antihistamine. That's it.
Yes. So viral induced wheeze treatment first a reliever inhaler such as salbutamol. From short acting, we are starting salbutamol. Then steroid tablet prednisolone 2 to 3 days are used to settle down the inflammation of the chest. Then Montelukast tablet and ipratropium inhaler. And most children with viral induced wheeze will not need a regular preventer inhaler. So just only inhaler we are giving. We are giving steroid 2 to 3 days to reduce the inflammation. We are giving Montelukast if needed, ipratropium bromide. That is, and also you avoid the triggers. So what are the asthma predictive index viral induced wheeze?
Uh, uh, okay,
Okay,
asthma predictive. Yeah, I don't know, doctor.
okay. An asthma predictive index first used for children 2 to 5 years with episode of wheezes during the first 3 years of life. At least one diagnosed by doctor. The predictive are major criteria and minor criteria. Major criteria are parent says history of asthma. Parent. Then doctor diagnosed atopic dermatitis, sensitivity to allergens in the ear, as determined by the physician through positive skin test or blood test to allergens such as trees, grasses, weeds, molds, or dust. So major are three, like parent had history of asthma, doctor diagnosis atopic dermatitis, and sensitivity to allergens. Minor criteria are blood eosinophil more than 4%, wheezing unrelated to cold. So without cold, wheezing. Doctor diagnosed allergic rhinitis, patient with allergy to milk, egg, and peanut. Okay, how can you differentiate between viral induced wheeze and the asthma?
Yes, yes. Virally induced V's, it is only one trigger, and like a cold, viral infections, and multiple trigger V's. This has multiple triggers. Also, yeah, it has multiple triggers. Like it may be due to pollens, it may be due to patch dander, and smoking. And
Yes.
in virally induced V's, the child is well, and there is only this attack, but in multiple trigger V's, like in asthma, so there will be in between the attacks, there is also symptoms, and
Mm.
family history is also positive in multiple trigger V's and greater
So
than 5 years.
greater than 2 years.
Okay, yeah, greater than 2 years. Yeah.
So viral induced wheeze and bronchial asthma both come on history, and we keep DD. If viral induced wheeze we top, then DD bronchial asthma, early onset of bronchial asthma. So how can we differentiate? Ask that. Viral induced wheeze, it is an episodic only during the viral infections. And multiple trigger wheeze, the bronchial asthma, later on plus minus cold weather, exercise, excitement, pet, smoking, pollen. So multiple triggers. Episodic viral induced wheeze, that is child otherwise well. In between the attack, the child will be well. But multiple trigger wheeze or bronchial asthma, there is interval symptoms are present between exacerbations. Wheeze, cough with activity, excitement, and cold weathers. And viral induced wheeze, no personal or family history or atopic disorder, where bronchial asthma, there is positive family history of asthma or atopy. Viral induced wheeze less than 2 years and more than 2 years in bronchial asthma. So, how discharge? Can you tell me how can you discharge the child?
If the child is stable for more than 4 hours, if 4 hours he is stable, and all the vitals are stable, and yeah,
So I am telling you, discharge home the same day if child had made a significant improvement and has remained stable for 4 hours. So 4 hours. Crop also mild crop, moderate crop we 4 hour observations. If improve we the same day discharge. Then parents we give some advise, some technique like understand and use the inhalers. Have a written personal asthma action plan. PAP. Have a written discharge and winning salbutamol information leaflet. Know how to recognize the sign of deterioration and actions to take. Discharge treatment we are giving beta agonist with spacer. So we are giving hair spacer. The child is less than 3 years with mask. If more than 3 years without mask. Give prednisolone 3 to 5 days and educate on use of PEF meter if age is more than 5 years. Discuss follow up in either community nurse. About the trigger, future management, and if he have life-threatening feature relief, pediatric respiratory specialist. So respiratory specialist or pulmonologist we refer because if there is life-threatening conditions, these are. So the advice discharge is when 4 hours observations. If improvement, we discharge. When discharge, we give some advice, mother, like how to use the inhaler, how to spirometry, the signs of the child is deteriorating, life-threatening asthma. The nurses, local community nurses, he will be contact, and the asthma treatment we give. That we know that short-acting beta agonist salvitamin inhaler we are giving 2 to 5 days. We are giving steroid. We are giving montelukast, ipratropium bromide, and these are okay. So this is all about viral induced wheeze. Thank you.